and welcome everyone. This is a video demonstrating some really useful techniques that I've learned over the last 20 years working with uveitic cataracts. I had a horrible case prior to learning this technique where a normal routine cataract in a very well controlled UV eye ended up with cyclitic membrane and going to full NLP. And that case haunted me, so I worked on finding new techniques, and this is one of them. Don't stretch the iris in a uveitis eye. If you stretch the iris, it will bleed, it will cause increased inflammation, and make your post-op that much more difficult. But do this, if you go in, you can usually find the little membrane. If you look at the synechia before the first manipulation, you can usually find a membrane, and you can grab it and pull it off of the iris tissue. That is not iris, that's membrane. And now I can round out the pupil and get a much more reasonable dilation for cataract surgery. So this is my usual small pupil technique, and again, don't use rings, don't stretch. We've got to keep the iris manipulation to an absolute minimum that is needed for the case. So here we have our rhexis, and then we do a little hydrodissection, nothing special, just normal small pupil technique. Including the next step, which is one of my favorites, is the Myloop. Using the Myloop allows me to decrease phaco energy, decrease flow inside the eye, and just ensure that the case is that much less likely to run into complications. The last thing we want in a uveitic eye is capsule rupture, vitreous loss, all that stuff that is very damaging to a regular eye is much more so in a uveitic eye. These eyes tend to be intolerant of everything. So a couple nice chops with my loop, and then you'll see this is a standard Centurion phaco bevel down, and notice how I can stay right in the middle. The pieces come to me because they've already been pre-chopped with the Myloop. It's just such an outstanding technique. I can't recommend Myloop enough for cases like this. If I could do it for every case, I'd probably try. So here we go. This is the first other useful technique is the handoff, where we leave the phaco tip in, throw in some viscoelastic prior to removing the tip, and that keeps the chamber stable and keeps the iris under control. These iris have a tendency to want to come out the wound. So here it is again after the IA, same thing, nice and controlled. And then another technique I find very helpful is capsule polishing, and I do this for all of my cases. I think it makes for a more stable post-op refraction, but for uveitic eyes especially, we want to get anything inflammatory out of that eye. So here's the lenses in. I didn't show you that final IA, and I try to sneak out without causing any issue, and the iris comes right out. So this is what these things like to do. I could have tried a BSS handoff technique. I find that really hard to do, but I will try it sometimes in certain cases when I have a very small eye and a floppy iris. And this is the study that just changed my world, the intravitreal triamcinolone for diabetes, and the Tufts group out of Boston in 2002. When that came out, I started doing this technique. That's 2 milligrams of Kenalog. We do that in 0.05 cc. And that's 2.5 millimeters back. Most important thing is put the tip on, then take your head off the scope and reorient the syringe. It will be in the wrong orientation. You're going to put this in. This is undiluted. There's no need to dilute this. This is preservative free. It goes straight in, and there we go. We see beautiful triamcinolone in the vitreous cavity, and it makes an amazing difference. I can't recommend this technique enough for uveitic eyes, and strongly advise against not doing this technique. Alrighty, thank you so much.